Well, family history, environmental, all of that, absolutely very important. I mentioned earlier I grew up here in Chicago, but I actually was born in Jamaica, where prostate cancer is rampant there, and there's lots of reasons why we could say that. Number one, they don't get screened; they don't come in to be screened. But even worse than that, they don't come in to see a physician to get checked out for anything. So, of course, if you what you don't know in that case will hurt you. So anyway, my story, well, let me go back to my father. My father, somewhere about 10 years ago, he'll be 80 years old this year, had a high PSA, and he underwent his first biopsy. But prior to that, another member in our family had actually, living in New York, had actually called and told me that they diagnosed him with prostate cancer. And he was actually about 20 years older than my dad. So if he was alive today, he'd be 100 right now. And Uncle had some other issues. And of course, when I heard he had prostate cancer, I'm like, oh my God, I'm going to lose an uncle to prostate cancer. But lo and behold, got treated. He was fine. He ended up dying from a stroke probably, well, I think about 10 years ago now. So I know I had prostate cancer in my family. I know that I came from a region of the world that it was very rampant. And then my dad, 10 years ago, his PSA went up and we did a biopsy. Lo and behold, it was negative. His PSA was, I think, 8 at the time, twice what it should have been. So of course you're not going to do anything about that other than if he's having trouble, what we call prostate hypertrophy, trouble getting the urine out, problems with the stream, getting up at night. We call it nocturia. But he wasn't really having too much of those symptoms that bothered him enough. So a couple years later, the PSA went up just a little bit again. So I think on the 3rd year, he got another biopsy. Negative. He subsequently had 3 biopsies over the last 10 years. Most recent one was about 1.5 years ago. His PSA is now 12, and the biopsy is negative. Now, moving on to my story. What you got to understand with the biopsy, typically we take 12 specimens around the face of a clock. So we try to hit both sides of the prostate, left and right. We try to hit the top. We try to hit the bottom. Jeff could probably expound on this a little later. And we give this pathologist 12 what we call cores. And the pathologist, and they're all marked as to where they come from. And then the pathologist takes a look at it and does he see any of these cancer cells, and he grades them, just like Dr. Steinberg had said. And a mid-grade would be like a 6, 3 plus 3. A horrible, worse, would be a 5 plus 5 or 10. Minimum being 1 plus 1 equals 2 is how they grade them. So since I knew that I was at risk, when I was about age 44 or 5, this would have put it back in 2002 or 3, I had my PSA. At the time, my PSA was 3. Even as a physician, I didn't know what that meant. I mean, what do? I have no symptoms. It's 3. At that time, normal was 4, up to 4. So I chose not to do anything. Had another PSA the following year. It was still 3. Okay. Maybe I have an enlarged prostate. You know, at my age, at 45, you would expect it more of a 1, 1.5 or something like that. But being African American, well, you know, you pat it a little bit more. So that brought us up to about 4. So I didn't do anything in 2005. I didn't do another PSA in 2006. So in 2007, when we moved our American Cancer Society headquarters in Atlanta, that was the hallmark year for me, I had another PSA done. And at that time, I was 49 years old. And lo and behold, the PSA was like 7. So over the 3 years span, it had gone from 3 to 7. Clearly abnormal. So now, what do? My choice was to get a biopsy, obviously. I got a biopsy, and remember now those 12 points? Well, the pathologist reported there was one of those 12 cores that had 1/10 of that core cancer. Now, I would say that's like a drop of blood in about 100 gallons of water. It doesn't change the color. What do? It's prostate, the cancer's there. I mean, I can go through all the mental stuff of, well, maybe in the 12 they missed a few others. They could have gone a little higher, maybe got some more. But you know what? That's the evidence that's there. You've got 10% of 1 of 12 cores that's got prostate cancer, and the grade is 3 + 3 = 6. What do? I've had patients with that who have said, you know, cancer's there, cut it out. I've had patients who were beyond what I would call a surgical candidate who said, well, can I do radiation? And I've had patients who have said, Doc, I'm going to listen to you what you say. I'm not going to do anything other than to keep coming to you to keep an eye on this. Well, that was my choice at the time. I did not think that any evidence was out there that any treatment at that time, even at age 49, was going to be a benefit to me. I think what I needed was watchful waiting. That was 2007. In 2008, the PSA went up just a little bit more again. So we went back for another biopsy. 12 cores, and what do you think this one showed? 0. No cancer. Am I cured? I don't think so. Is the cancer growing rapidly? I don't think so. Should I continue watchful waiting? Heck yes. There's no way that I'm going to subject myself to any treatment based on all the evidence that's out there. Left it alone. Come along to 2009, we skipped the biopsy. In 2010, we thought we should do another biopsy again. The PSA still high, hadn't really gone up very much, but it was still high, and since it had been 2 years, thought it best, go ahead and have a biopsy. This time, out of the 12 cores, most of them had cancer, and it was significant enough that there was grade 3 + 4, which was 7, so it was a little more than it had been before. And the fact that over a 2-year span, or 3 if you count the original one, it had gone from a drop of blood in Lake Michigan to changing the Chicago River green. You could see it. And at that time, we had to make a decision. Now, it brings us back to everything we've talked about. How do you tell which cancers are likely to cause the death of the patient? The ones that appear to be more aggressive. Well, you can't be more aggressive than finding a drop 3 years ago, and now 3 years later, you're having it in more than half of the biopsy samples. So at that point, you need definitive treatment. So the definitive treatment usually involves one of 3 things. Either radical surgery, either radiation, as Dr. Steinberg talked about, every day for 7 weeks, or radiation implants. And the data on all of those are still sketchy. There was a study done in Europe that says that radiation implants for patients are good at 10 years at the time that my diagnosis was made. Well, is 10 years good enough to offer someone who is 51 years old, who has a life expectancy, hopefully, of at least another 25, 30 years? Wouldn't be the same if an 85-year-old came into me with that diagnosis. So my choice at the time was a radical prostatectomy, which meant that they removed the prostate and some of the other tissues and stuff around, including lymph nodes, to basically fully stage the disease. Now, it comes not without harm, as you've heard us talked about. There are lots of complications that may develop when you have prostate surgery or even radiation surgery. I'm treating a patient right now from outside our area who had terrible radiation damage to his lower bowels, which he had radiation 4 years ago, and now he's having the side effects from it. So it can happen. But at surgery, the risk include incontinence, meaning constantly leaking the rest of your life, to some degree, or none. Some people have complete recovery, or sexual dysfunction, impotence, to varying degree. So all those risks got to be weighed. And then there's some unseen risk. Well, I underwent surgery about a year in February of 2011. So it's 15 months ago, February, March, April, May, yeah, about 15, 16 months ago. And I had a radical prostatectomy. We used a robot, and the operation performed by a surgeon, a urology surgeon, who was a good friend of mine who had had very successful operations on several of my patients, both African American as well as non-African American. Well, I developed a complication that none of us thought about. It wasn't impotence, it wasn't incontinence, but doing surgery, one of my legs decided to go to sleep and didn't want to wake up, so to speak. It's called compression syndrome, and it almost led to loss of my left leg. I went surgery for my prostate on Friday. I ended up back in surgery emergency Saturday for my leg, back again on Monday, back again on Wednesday, and back again finally the following Friday, where I had a skin graft and closures and stuff done. Instead of 2 days in the hospital, I spent 14 days on the medical surgical unit, 7 days in rehab, 3 months not working, and 5 months in outpatient physical therapy. You talk about complications. Now, take us back 4 or 5 years ago when I had that drop in the tiny drop. If I had had this complication because I had done surgery back then, or I had referred a patient to surgery for having that small drop and they developed a complication like this, I would not have felt like I did service to that patient, because that harm certainly was a whole lot worse than the benefit that could have been obtained back then. If 4 years after this I'd gotten another biopsy that showed one drop again, I was going to continue waiting, which I think would have been the right thing for me, the patient, at that time. And I didn't do it in isolation, obviously, but I certainly did it with a lot of perspective. And I think one of the first persons I recruited was Dr. Brooks, and I still have his book. But thankfully, right when I leave here today, I'm hitting the soccer field. We got a game at 5 o'clock up in Evanston.